Morning, folks. Let me begin the meeting with our land acknowledgement statement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across barriers of heritage, and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respects to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. All right. I will call the meeting to order. I understand from Jill that we do have a quorum. I am hoping to share as our first agenda item some data relative to the provider bed utilization services, and so I will provide that. Morning, Mike. Can't see other folks, so hopefully can see the screen share there.
Yes, we can see it. Thank you.
Super, thank you. I thought very briefly I would start with, just as a reference point, this is actually 2022 data. I'll drop down to the 2023 data in a moment. But wanted to be able to share with folks the first quarter and of course, you know, the total for the year of 2022. And so what I do is I gather data information relative to available bed days. You can see there that is essentially just the number of days in the month. You know, that is a quarter's worth of days. And then the utilized beds is actually individuals admitted and in a bed at midnight for each of the facilities. And so that's how we establish that number of utilized beds. This is a percentage, obviously, of the available beds and the utilized beds. And then some additional information of unduplicated individuals that were served, the total number of referrals, and I can talk a little bit about the referrals themselves that were received during the quarter. So law enforcement, emergency medical services, the LEAD program, GRACE, mobile crisis outreach team, Peace Health Hospital, jail transfers, all other professionals, self and family reference, and then base camp. One of the things that I wanted to just, you know, provide and bring to folks' attention, and I'll bounce back and forth here a little bit, and then I'll stop on the 2023 utilization data just so that people can ask questions. But I wanted to bring to folks' attention that this is relative to the detox. This lower portion is the mental health stabilization facility. And with detox, they had in the first quarter of 2022 a 74% utilization of beds, which is a good number in my opinion. There is still availability of space, but 74%. And what I wanted to do was just to sort of drop down to 2023 as a comparison again. This is detox. They've had a 78% bed utilization for the first quarter of 2023. Relative to, again, of course, the same program bed dates because it's based on calendar, utilized beds, etc. Compass Health providing mental health stabilization in the first quarter of 2022 was struggling some with a 50% utilization of beds. That was related to staffing challenges and any number of challenges. Obviously, we were still involved pretty extensively in COVID and some of those challenges. unduplicated individuals served, referrals received, law enforcement 15 through that quarter, EMS 2, Lead, Grace, and MCOT respectively. Peace Health is a significant referent to the mental health stabilization side. And then all of their professional self and family and base camp. Again, this is 2022. For that first quarter at a 50% bed utilization. I consider it to be a pretty significant process as we've moved to 2023 and completed that first quarter bed utilization at a 70% utilization. I think that there are a number of factors that are going on here to see that increase. Compass Health was able to fill their vacant positions. Obviously we've had, improvement relative to the COVID challenges and issues. They also implemented right towards the last quarter of 2023, implemented a streamlined admission process, particularly oriented towards law enforcement, but not limited to law enforcement. And I think that those particular factors have had a fairly significant impact in terms of bed utilization dates that we are targeting. So I will leave this data here for a moment. I obviously at the bottom was just doing a running total, and of course it only reflects at this point in time the first quarter of 2023. So I'm pleased with the efforts that the providers have made, relative to utilized bed dates, and also the referrals. I know that law enforcement have been continuing to attend our Crisis Stabilization Center Advisory Committee, which happens in the first Monday of each month, just to understand further how best to utilize the Crisis Stabilization Center and the importance of the Crisis Stabilization Center as a diversion from for individuals that are high utilizers of emergency services and law enforcement, those kinds of things. We are seeing pretty significant involvement and referrals from the mobile crisis outreach team. Those are our designated crisis responders that are determining whether an individual, following a call, they determine if an individual meets criteria for possible involuntary treatment admission. In that given situation, if they don't, they will, of course, transport them to the Crisis Stabilization Center, where an individual can actually go through an ITA evaluation and be placed in the hospital, but not necessarily if they don't meet criteria. So just want to offer that, that piece. Yes, Paul, I see your hands up.
Yeah. Wanted to know, I was reading the chart a little bit. It seems like that Peace Health is a big user or big referral body here.
I would absolutely agree with you. A couple of things. Obviously, this is referrents that are coming to the emergency room and or being considered in terms of being taken into a setting there for psychiatric treatment. So a lot of individuals will initially make contact with a professional there. And then as appropriate and with communication, then Peace Health will make a referral to the Crisis Stabilization Center as a more appropriate level of care for that individual. But they are a significant user, and I appreciate your awareness of that. And one of the things that's been very much appreciated and I think helpful is Peace Health representative does attend our Crisis Stabilization Center Advisory Committee meetings on a monthly basis, so that we have good communication in that regard. And we've also recently initiated a secondary meeting just related to Peace Health admissions there. And processes relative to individuals that are struggling with serious mental illness and are in need of services, because there was just some challenges there. And so since we had law enforcement EMS and others attending that meeting as well. I think that really has opened up that communication, and those meetings are continuing. They've just reinitiated, I believe it's on a monthly basis at this point, to discuss all matters related to Peace Health and utilization of crisis stabilization.
One more thing that to me, it's pleasing that for detox, self and family is heaviest utilizers of this service, which is a great thing. And, it means that public is very aware of this thing, families who are going through this crisis in their families, loved ones, friends, that they are good users and other professionals too. My intention of bringing Peace Health is that we appreciate their participation and use of this facility, but at the same time, they should, are they getting us any help, financial help for our needs?
At this point, the Crisis Stabilization Center, as you of course know, is the building is actually owned by the county. We do actually have a lease agreement with both of the providers at roughly, if I recall correctly, at $2,000 a month for the use of the facility. Obviously, county facilities maintains the building and the setting and so forth. The providers actually bill managed care organizations directly, most often for individuals that are Medicaid recipients, not always, but for the most of them. And also our North Sound Behavioral Health Administrative Services Organization has a fund that if individuals are not for some reason eligible through Medicaid, that the providers can directly bill the BHASO for those services. As you know, we are struggling just relative to reimbursement rates, relative to Medicaid, which is a significant challenge. And one of the things that I was going to share with the group was that I recently saw a letter from Pioneer Human Services talking about some very significant deficits relative to their operational costs, not specifically with Crisis Stabilization Center, but with many of the other programs that they provide in the North Sound region, which is absolutely of concern.
Yeah, so because if we look back last 10 years or so, or even more, Peace Health used to have all these referrals and all these people used to go there, and it was a burden on them. They had to eat a lot of these things, because when people can't come there, they're not reimbursable, then Peace Health used to foot that bill. And I think that it is great that our county or our community or state has helped us to do this. At the same time, I think that we could have some conversation with that organization. I mean, they are the only one hospital we have, and they may have some affordability. I don't know. But this is something is worth asking the question to share our deficits and our challenges, what we can discuss with them, what we can at least bring it to their attention that we have some challenges.
Understood. I appreciate the perspective and have made note. I think that that's certainly a viable thought process, and we have a venue to be able to initiate those discussions and conversations as well. Appreciate that.
Okay, thank you. That's all I had.
Yeah. Hi, Jack. Don't know if you were, I know you were going to be a little bit late. Jill had shared, I want to just touch base briefly. This is obviously 2023 first quarter. Utilization for this upper one is detox. The lower one is the mental health stabilization. We had a 78% utilization of bed days, available bed days for detox in this first quarter, and a 70% utilization for The mental health stabilization, I'd shared with the rest of the group the 2022 data. The first quarter detox had a 74% bed utilization during that same period of time. And as you recall, mental health stabilization was really struggling in the first quarter of 2022 and was at a 50% bed utilization. So we've seen an increase in obviously referrals. We've seen an increase in bed utilization for 2023, 78%, again for detox, and 70%, quite a leap for Compass Health, mental health stabilization and the services that they offer.
So very quick question, and thanks, sorry I was a few minutes late. Also, I think part of that 50%, they were having some process problems as well. I mean, I remember that those numbers wouldn't reflect long-term. My question though is, in my mind, I wouldn't want to see, unlike a hotel or a cruise ship, I don't know that I want to see 100% utilization, because if I've got 100% utilization, it often means there's no room in the inn, so to speak. So there isn't ability to get people in. My question for you is, what in this realm, and in the realm of crisis stabilization and detox, is there an ideal number? Is 90% ideal? Is 60%? Is it considered widely best to have 100? I mean, my concern would be if Whatcom County were much larger and we always had 100%, we go back like to the old detox, which was virtually 98%, but there was never any room. So I guess I'm just curious what, maybe informally or in your mind, what the target, like what's ideal?
You bet. I really appreciate the question, because there is, of course, a lot of movement of people coming in and completing, being discharged, et cetera, that occurs. Conceivably, an individual can be admitted and then possibly not be willing to stay. And if they do leave before midnight, that bed is not counted, so those are a number of the different components. But from my perspective, as we reach an 80% utilization, that is, we're nearly at capacity at that point, in my opinion. And somebody could certainly, not agree with that, but being able to reach that 80%, and sometimes, of course, exceeding that in a particular month, I think that we are really maximizing the available capacity of the facility, the staff, et cetera. So that's not based on any research that I've done in particular, just communication with providers and those sorts of things. And so I worry about, of course, reaching a capacity of where first responders and et cetera are like, don't even bother going there. There's no available beds. It's a success on one level, as we were talking about, and it's also, a challenge on another level.
Well, yeah, and I see Doug's on here, and you recall all the conversations we had trying to make sure law enforcement, I mean, part as it relates to the task force, the goal was in large part for this to be a resource for law enforcement, in addition to the other community benefits. If we don't do that handoff right and make it quick, it doesn't get used. So that's in the same, in my mind, back when Chris Phillips was involved with Peace Health, they really wanted it to be successful to free up the ER. So I think, keeping those things in mind. And I think sometimes with these statistics, the public may look at it and go, well, you're not at 100%, what's wrong? And that metric may not reflect what we're trying to achieve all the time. Maybe in our annual report, we communicate some of that we don't want to be 100%, because that would mean we can't be available. At least that's my instinct. So anyway, those are just a few thoughts. But I'm trying to measure, are we achieving the goal we set? And to me, that upwards of 70-75% is really good, because you've got a lot of beds filled. There's a lot of activity happening, but hopefully if Doug's got people out in the field, or Sumas or whoever, they can call in and get somebody dropped off. And that's the other, intent of this, because you can't divert from jail if there's no beds.
Right. That is, I think, astute, just in terms of that perspective. And I guess I'll, at this point, throw in another component, and that is that the other mental health triage only crisis stabilization center that is geographically near us is actually being closed in Everett, Washington, Snohomish County. Compass Health provides those services there, and the building that they have historically used as a 16-bed crisis stabilization center that is for triage only, for mental health only, is being demolished. And the estimates are that that facility will be closed for an 18-month period of time. I know the time frame is imminent. I think it's within the next month that that will actually occur. So there's some concerns just relative to, you know, our region's needs and the possibility of an additional demand on mental health stabilization services within Whatcom County. We do track, although I don't have it in my data, I know that the provider tracks the address and residence of individuals. And so my plan was to meet with the provider and just draw some of that data as we go forward. Not that we don't want to support our region in general, but that there could be additional concerns to what you're making reference to, you know, just in regard to capacity for the facility. Again, it's not true for detox facilities. There are some detox facilities between Everett and Whatcom County. And so I don't expect necessarily to see overflow with that. But I did want to make reference to those events occurring within our region. So I appreciate, Jack, the reference, and of course, we're going to talk about annual report just a little bit, that we would want to include, you know, just a statement relative to capacity, 80%, you know, available beds, those kinds of things. So I appreciate that.
Thanks. Yeah, I don't know how others feel, but I'm assuming a lot of us would think if it isn't 100, maybe there's a deficiency. And in this case, I don't think that's accurate.
Right. Other thoughts, comments? Just in regards to, there are, you know, and we're measuring, you know, available bed utilization and that sort of thing. We continue to focus on and work on quality improvement. Just relative to services. I've mentioned before, and I think that it's worth mentioning again, that we do have a systems improvement form that is available on the county website, and continue to talk with providers, you know, a variety of individuals, that if they experience a real positive process and experience of being able to get an individual admitted or support an individual in being admitted, and or if they run into challenges, that systems improvement form is completed. It does protect an individual's personal health information, but once that online form is completed by any individual in the community that has access to it, a copy of that actually is comes to my email directly. And I typically will follow up that data being coming to me by making contact with the individual that has submitted the form, just getting a little bit more information. And then I also will forward it to the manager of either detox or mental health triage, whichever it happens to be, to gather a little bit more information there, because all the information isn't necessarily in the form, but it helps us to take a look at trends, that sort of thing, relative to admissions and challenges that that occur. So it's not just about use of beds per se, but of course about quality improvement as well. I felt supported by both of the providers in terms of their response to and attendance at our Crisis Stabilization Center Advisory Committee as well. So that's just another component of that. Any other thoughts or comments just about data and utilization, that sort of thing? All right. The second agenda item or sub item of the updates was relative to 12-hour law enforcement hold project. I think that folks are probably aware. I'm going to share my screen here again, and it's going to take me just a second. There is an RCW 1031-110 that allows for the process, or there's legislation that is specific that a crisis stabilization center can be used as a 12-hour law enforcement hold. And so I can share that RCW with folks, briefly, just to sort of show you those components. And so a couple of steps that have occurred. We had directed Compass Health. It is only for mental health stabilization. We directed Compass Health to pursue a specific Department of Health certification for those 12-hour law enforcement holds. And specifically, the reason that I see in that is that, as folks will remember, our Crisis Stabilization Center is a voluntary program. The building is not locked. And sometimes there's some confusion about that individuals, if they choose to, can request to be able to leave. Staff will work with them using motivational interviewing and other processes to attempt to engage them further in services. But if the individual requests to leave, then that is how the facility is at this point set up. 12-hour law enforcement holds are, again, a legislation that allows for what is technically termed an involuntary hold. That is that a law enforcement personnel can take an individual that's committed a low-level crime to the Crisis Stabilization Center and essentially have a conversation with the individual and notify the the mental health triage staff that this individual is on a 12-hour law enforcement hold. The expectation is that the individual remains at the facility for a minimum of 12 hours. Obviously, we're going to encourage the individual to remain longer if that need is there. If the individual does demand to leave prior to that 12-hour period of time, the legislation, the statute actually specifies that the law enforcement office will be contacted at that point, and they would be notified that the individual had departed. So this really brings some challenges for law enforcement, obviously, in relation to, okay, the term that I have used before is that mental health triage staff cannot go hands-on with the individual. That is, they cannot forcibly detain them. The licensure doesn't allow that and only allows for notification of the law enforcement office. So there were some real concerns about the facility setup in terms of it being voluntary, the staff and et cetera, and that sort of flying in the face of that. So Doug, I'll absolutely have you share, and I'm gonna share my screen while you're talking if I can.
There we go.
Yeah.
No, I just, I know you've been meeting with some of our operational folks, and we had a meeting with the prosecutor's office. Obviously, prior to the involuntary status of the Crisis Stabilization Unit, for years we have used 7105 as far as taking people into protective custody, using the hospital to bring them in, get them evaluated, and make that determination there. So I think we're still working through, even though it's certified as involuntary from a law enforcement perspective. Under, we can take somebody when we have reasonable cause that they've committed, and I think they've actually modified the RCW to it's no longer a low-level crime, it's committed a crime, but we also have to consider what's the seriousness of the crime. What's the mental health history here before our folks are making a decision to take somebody to the Crisis Stabilization. So I think what you're going to see still, until we really get that refined, and I know we had a conversation with the prosecutor's office, they did give us some guidance. Unfortunately, I can't really expound on the specifics, but needless to say, we view the involuntary status of the Crisis Stabilization Facility as that's a discretionary option for our officer when they deem that it's appropriate. But we also understand if we drop somebody off there, it's not a secure facility. They may be held for 12 hours, but like you said, if they want to leave, they're going to be able to do so. So it's really that conversation about, we have probable cause essentially for a crime, and we feel this is a better option for you, and encourage somebody to go there. So for those people that we believe are gravely disabled or are an imminent serious risk of harm to themselves or others, we're still going to likely use the hospital for that function. But then we're gonna, evaluate and kind of triage where folks are at if there's some criminal activity involved. But there's obviously evidence that maybe the root cause of this is some behavioral health issues. But I know we'll continue to do that. And there's some discussion in 1031, 110 too about not only establishing guidelines in conjunction with the prosecutor's office. And again, that may be similar to some of the criteria for the LEAD program, but also engaging, defense counsel and other people about, what crimes and who's really appropriate for that 12-hour law enforcement hold. So it's a work in progress, but again, that is still a discretionary option for us to use to drop folks off there. And we hope to use that. I think with the fact that when you were looking at your data, obviously MCOT uses that facility, for the county. MCOT has kind of been our go-to resource to get people the services out in the community. And now that we're transitioning to the co-responder model where we have behavioral health deputies and behavioral health specialists partnering and responding, I can see maybe a little more utilization of the crisis stabilization facility under 1031 100s. So
yep,
we will keep working on that.
Thanks, Doug. And I think that folks are aware that the health department, specifically Response Systems Division, has a great relationship with the Whatcom County Sheriff's Office, very involved. Doug mentioned the behavioral health deputies, very involved, great feedback, and attend a number of meetings just in terming understanding and some of these components. So Doug gave a great overview just in terms of, again, 1031 110. I can send this out to folks if they want to look at it. But the short version, and I highlighted these components that we've really described here in the meeting relative to the fact that this is an option. Of course, legislators created this, and there are some challenges on an individual level for law enforcement officers and that sort of thing, that simply saying that it is available doesn't necessarily make it, necessarily a choice that is the best particular choice, and very much on an individual basis. So essentially this part that I highlighted is just making reference to the fact that legislation does allow this process. And more specifically, if I can, coming down to the section of where, and I bolded and highlighted that section, that a police officer must be guided by local law enforcement diversion guidelines for behavioral health developed and mutually agreed upon with the prosecuting authority, with an opportunity for consultation and comment by the defense bar and disability community. So in regard to this component, I'll take that down just so that we can see each other. What I wanted to be able to share with folks is that I think I'm referencing him correctly, Chief Gum and myself and Prosecutor Ritchie met and talked about this dynamic, because obviously the prosecutor's office needs to be involved. As Doug had mentioned, the Prosecutor Ritchie had actually forwarded the information and et cetera to I think that folks may be aware of, let's see, I just want to make reference to his name, Senior Deputy Roche, that is part of the county attorney's, prosecuting attorney's office, was concerned about liability for the county relative to implementing this, and again, related to the voluntary status of the facility and it not being, a lockdown facility, and some of those details and components. And again, Senior Deputy Roche forwarded his recommendations to the sheriff's office, viewing, I think appropriately so, the sheriff's office as being his client, and indicated this is, something that information will continue to be discussed back and forth. That wasn't something, the specific information wasn't provided to me again Not that that was not appropriate, but I don't have the detail of that information at this point. But again, have the relationship with Whatcom County Sheriff's Office and plan on continuing to work on this and look at protocols and procedures as I can, those kinds of components. The other thing that I'll say is that obviously City of Bellingham Police Department is another component I have not yet completed, but I need to complete communication with the Bellingham City Attorney relative to utilization of the facility as a 12-hour law enforcement holds. And that is my next step in this whole process. So just as a summary, Compass Health has the staff hired, has completed the certification for this necessary for this process to be in place. So they are available to implement availability of 12-hour law enforcement holds. But there are some pieces that we're working through here just in terms of risk and legality and et cetera. So wanted to update folks relative to that. Thoughts, comments, questions about that component? Really wanted to say that I appreciated Chief Gumm's involvement too, under Sheriff, and just was really helpful. Wasn't sure exactly how to bring that piece together, and so Chief Gumm was really helpful in that whole process. So,
like I said, I think it's a work in progress. We really need to refine those guidelines, and I think there's a meeting later today, and I'm assuming that will probably come up as well. So,
okay.
But again, for us, we still see it as an option, and we'll evaluate it on a case-by-case basis and bring folks though that we feel are most appropriate and would benefit from that. But also trying to weigh the, understanding that it's not a secure facility and what's the risk. And just anecdotally, both from law enforcement and I don't want to speak specifically for EMS. I know Mike Hilly's here, but talking to some of the fire service, they said they've run into issues where, and I don't know the specific criteria, just people weren't being accepted into the facility for whatever reason. And I know going way back to the original triage center, that was always an issue. And like we talked about very early on, if we establish a facility and the criteria are so restrictive that we can't get people into the facility, first responders will stop using that as a resource. And I don't want to say that that's what's happened, but obviously early on, one, because of the staffing, two, because the criteria hadn't been quite finalized, it was not being utilized. And I think people just disregarded it as a resource. So I think as we move forward and refine that, we talk to the prosecutor's office and everybody's comfortable with who's most appropriate to be in there and mitigating the level of risk and liability, I think it will be utilized more often. And like I said, I think with the co-responder program, I think that's just another piece of the puzzle that will really highlight that as a resource that hopefully we can utilize more often.
Yeah, I would really agree. And I'm really excited about the collaboration that development of the response systems division, just in regards to, the GRACE program, the LEAD program, being able to use that, obviously the community paramedics and that communication. If it weren't for that level of collaboration, I think that this would be a far more difficult road, to accomplish, obviously, as well as when you're making reference to the behavioral health deputies, as well as the alternative response team and their very close utilization in terms of crisis stabilization center. We get immediate feedback if there's challenges. There's a lot of communication relative to admissions, because again, from the perspective of the providers, the other thing that we did from the original triage program, which was actually social detox, for example, there was no medication involved in, et cetera, to moving to a medical detox. There is, and again, of course, we're seeing some real differences in terms of the substances that are predominantly being used out there in the community. There's an increased risk of individuals' primary health safety when it comes to being admitted to a facility, the facility not knowing what medications are on board, you know, those kinds of things. And it makes it very challenging in terms of the admission process from the providers wanting to limit their liability at the same time of providing services. And so, you know, pulling those agendas together and challenges together, I agree. I think that that'll be a continued process of communication, and we have hope for that, you know, by virtue of the close collaboration that's occurring. So really appreciate that piece. Other thoughts, comments, or questions, or I'll move to my last agenda item, which is really the 2023 annual report, progress and priorities. And so I pulled just very quickly from the 2022 annual report. It was broken up into obviously introductions, a brief overview of the facility and capacity and that sort of thing, as well as reviewing the census, monitoring the status of involuntary certification process, which has been completed, but you know, everybody is clear, I think, on where we are at this point. Reporting on the Crisis Stabilization Center Advisory Committee that meets monthly. And then some of the next steps that were listed in our 2022 report were data overviews, 12-hour law enforcement hold implementation, next step of operational funding, which we touched base on briefly here, and then continued streamlining of admission process and work within the Crisis Stabilization Center. So I haven't, other than just draft and some of my scratch notes, started on my 2023 annual report, but I'm very open to ideas and thoughts of what I should include beyond what we've talked about already. And so I just open it up to the group in terms of any direction, advisement that you might offer.
My only thought, period, I think I said this maybe at steering committee, is consider having a simple template of some kind that addresses some of the basic questions primarily around utilization that you could update, whether that's in the annual report or possibly in some, we actually have 2 reports a year to the council, the more formal one in June and the other one. So I think that would save you time if you just had to update the data and having some kind of, I hate to tell you what to do, but some kind of table or graphic or something that disseminates the information that we know is routinely asked, like how many are used. I mean, we can't answer the question of how many people were successfully diverted, for example, necessarily. We don't always know, but I think what information we can provide, particularly if it can be kept similar, will save you time and get people accustomed to getting that information.
I really appreciate that, and you know, very helpful. Maybe I can touch base with you as I sort of put something together and get just any input about components of that template or table.
Sure, and I think really simple. Just, I mean, even as simple as the data you gave us today, almost simpler. Like over the last year or our monthly average, I would tend to use whatever numbers look best, because sometimes the 12-month, for a variety of reasons, don't really capture what's going on. So I would use the numbers that really show, hey, this is how it's being used. To me, the goal of that is to communicate to the community and others interested the value in what's being done, both from getting people off the streets and diversion, and then the obvious public benefit of having a resource for people in mental health crisis or that are in substance use crisis and want to, you know, need a respite. So I think whatever data shows that simply is where my head's at. And I think that looks like numbers probably. And maybe a sentence of we've, you know, quadrupled our capacity from what we had 5 years ago or whatever that reality, that I'm pulling that out of the air, but we have probably quadrupled the beds overall. So we went from what, 13 or 14 to 32. So,
right.
Yeah. And I know that Doug and others probably can't keep track of who's diverted per se. But I think anything that, and nor would I want you, I get in the field, Doug, you know, there's things people have to do other than keeping all this data. But I think one of the things that builds trust in the community, that our whole system is designed to divert where appropriate, maintain public safety where necessary, is showing that data. So anything we can do to do that, especially if it's not too hard, is a great thing to do. And I do think that's the fundamental. I mean, the more I'm around this, the more I get. The only difference in opinion really is what's necessary for public safety. I haven't run across anybody that wants to lock people up just to be mean, not at all. So I think, but there are people in the community think that's the case, that they think we just want to lock them up. And yeah, so I think showing that that's our goal and how we're executing that is always helpful.
Understood. Thanks. I appreciate that that help. And Jill obviously helps dramatically and in formatting and just bring thoughts and ideas. So I will put pen to paper in regard to getting.
And remember, we're trying to be shorter this time because we think
Which-
council's got enough from us. We're trying to be a shorter report.
Right.
All
Which
right.
anybody that knows me well means that that's a significant challenge because, longer is, better in conversation for me, usually not in documents.
Well, who was it that said if I had more time, I'd have written you a shorter letter? It's like, that's not Fitzgerald, but it's some famous author. If I had more time, I'd have written you a shorter letter.
Yes. So I appreciate that, and I'm excited to be able to be a part of providing the information and honestly to be a part of the Response System Division as well as the Crisis Stabilization Center. It's a meaningful part of why I value the work that I do for the health department. So. All right, if there are, I think that we need to possibly talk with Jill about public comment. We'll move to that agenda item.
It doesn't look like we have any attendees today, so no public comment.
All right. Well, I very much appreciate everyone's time. If you have, additional questions or something, you can obviously make contact with me. I'm more than happy to provide that. And I just appreciate folks taking the time to attend. It's an important role that I play, in my opinion, and I feel proud of the fact that I do that.
One last question. Have you started thinking about that 23-hour facility we're going to do?
Absolutely. And honestly, I think relative to law enforcement and first responders, because of, the design and nature of a no refusal unless at capacity kind of dynamic, and the sort of a holding place for folks to be prepped to move into, and that communication, I think it's wonderful. And so I am very much, thinking about that process and talking about that process. I'm excited that that's a possibility for our county.
I'm very excited. I did go to Olympia and met with our delegates, and it's been just so wonderful that we will be the first one to prove it to the rest of the state. So
Right.
yeah. All right. Thank you.
All right. Thank you very much, folks. Have a great rest of the day.
Thank
Thanks,
you so much, Barry.
Our meeting is adjourned.